I'd like to thank Dr. Deason and Dr. Mohan for being with us this morning. Let's see. Dr. Deason joins us today as an associate professor of psychology at Texas State University, and she's also a faculty fellow within our research center here at Translational Health Research. Dr. Deason's educational background spans a really interesting breadth of subject matter, including expertise in software engineering, neurology, and she holds her PhD in cognitive and biological psychology. Dr. Deason's research interests focus on understanding how people learn and remember items, how memory is altered by aging or disease, and how we can use these preserved memory processes to improve our daily lives of older adults and for people living with Alzheimer's diseases. Today, Dr. Deason will talk about how memory changes with aging and dementia and consider strategies for dealing with these changes across the lifespan. Dr. Mohan, Ranjini Mohan, joins us today as an associate professor of communication disorders at Texas State University, and she is also a faculty fellow within our Translational Health Research Center on campus. Dr. Mohan holds a PhD in cognitive neuroscience and gerontology. Her research aims to understand the impact of age and a variety of interventions on cognition and language abilities in older adults. Specifically, her work seeks to understand the neural bases of cognition and language in typically aging adults and those with neurogenic diseases. I'm particularly excited to learn more and hear from Dr. Mohan today about her research and clinical experiences working with adults across acute, subacute, and outpatient care settings in both the United States and in India. Today, she will discuss cognitive processes impacted by aging and disease and interventions that can preserve these functions. So I will go ahead with all that said, turn the conversation over to Drs. Deason and Mohan for their presentation this morning.
All right, well, I'm happy to be here and thank you for the lovely introduction. So I'm going to get it started by talking about memory changes in aging and dementia. So next slide. But first, I want to highlight a group that both Dr. Mohan and I are a part of at Texas State, the Alliance of Researchers in Aging. So this is a faculty-led group bringing together researchers from both campuses and across many different colleges and departments who are interested in a wide variety of issues related to aging and dementia. So there'll be a plug at the end to check out our website and feel free to contact us about any opportunities. And next slide. All right, so back to the main topic. So to start us off, I'm going to ask you three questions. So just think about them in your head. How did you celebrate your last birthday? What is the Texas State mascot? And how do you ride a bike? So now, as you thought about the answers to these questions, and yes, I'm not giving you much time because I don't have much time, it likely felt different the way you were coming up with the answers to each of these questions. So even though all of these involve using your memory processes, your brain was doing different kinds of work for each type of question. So the birthday question taps into your episodic memory. So recalling individual personalized experiences with likely richer detail. The mascot question relates to your semantic memory or your memory for facts and knowledge. So not necessarily a specific event, just something you know. And the bike question refers more to procedural or skill memory. So you likely had a harder time answering this question as it's often difficult to put these types of memories into words. You just know how to do it. So this is to highlight that memory isn't just one thing. It's made up of different types of processes, likely working together at all times to help us take in and interact with our world. Next slide. Now, the flip side, when memory doesn't work quite so well. So, have you ever walked into a room and immediately forgotten why you were there? And have you ever had that awkward experience of knowing that you know someone's name, but you just can't quite get it? It may even be on the tip of your tongue. Well, so these memory problems are incredibly common and examples generally of how our memory systems work. So they are generally thought to be normal problems, but they do increase in frequency as we get older. So next slide. So, do these memory errors and the increase of them as we age mean that our memory is getting worse? Well, some types of memory do see decreases with the aging process, but not all. So, the ones that are generally impacted the most are episodic memory. So, the birthday question, remembering those recent personalized experiences. That type of memory does see less reliability as we get older. We also can see changes in our working memory or short-term memory. That's our ability to hold and use information in the moment. But it's not all bad news. Some memory types are maintained or even improve with age. So, that memory for riding the bike, the procedural memory, memory for skills and habits generally remains intact with aging. And semantic memory, so the mascot question, our memory for facts and knowledge, well, that grows as we learn new things as we get older. So wisdom comes with age. So not all memory systems show the same changes. Aging doesn't mean that your memory system is overall getting worse. It means it's changing. So some systems become less efficient while others stay stable or even get better. Next slide. These changes in our cognitive performance are also related to changes that we're seeing in our brain. So, aging is associated with an overall decrease in the volume of our brain, related to the loss of neurons and the connections between them. And in particular, we do see decreases in the areas related to learning and memory. So the frontal cortex and also the hippocampus, which is an area critical for the learning of new information, is generally around 20% smaller by age 80. Next slide. So far we've talked about what we would consider normal aging process. But it's important to distinguish that and to also talk about the impact of dementia. And in particular, I'm going to be speaking more towards Alzheimer's disease. So conditions like Alzheimer's disease lead to changes in learning and memory. And in fact, changes in that episodic memory system, that memory for recent experiences, is often a hallmark symptom of these types of dementia. But this goes beyond what we see in the changes related to more healthy aging. It is impairment in these types of memories that is significant enough to cause disruptions to activities of daily living. So it really can have an impact on individuals' lives. And in Alzheimer's disease, we do see those brain changes in those same areas, but again, to a much larger degree, as you can see by the slides here, that we see a massive reduction in volume as the disease progresses in those areas of the frontal cortex and the hippocampus, leading to these disruptions. But we also see that, similar to what I discussed before, the disruption in these different types of memory happens at different points along the progression of the disease. Eventually, they will all be impacted, but some of them are more preserved at the early stages of the disease. So I'm going to talk a little bit more about a specific type of memory and then some strengths that we might be able to work with. And that these are all related to research that I've done previously. So next slide. So we talked a little bit about memory errors. And typically when we think about Alzheimer's disease, we think about forgetting. But Alzheimer's disease also comes, as my research and research from others shows, with an increase in what's known as false memories. So a false memory is when someone might confidently recall an event that never occurred or mix up details from different experiences. So, for example, what this slide is to cue me to talk about is that if an individual is simply forgetting to take their medications, We can set them up with reminders, with check-ins, with lots of different scaffolding that can hopefully help them overcome that forgetting. It can become a little bit tougher to deal with, especially on the part of care partners, if you check in with the individual and they confidently tell you that they did take their medicines this morning. And when you ask them to check their pill box, they say they don't need to because they know that they remember taking it. And this is where, if we dive into that area of false memory research, it's sometimes hard to know whether that memory that they are retrieving is the memory from this morning, from yesterday, from last week. And so these false memories can become problematic, particularly when we're thinking about living independently. So my colleagues and I have been sort of very invested in making the case for more study into how these false memories work in dementia of different types, and also what we might use as strategies to reduce false memories. So next slide. So one of the ways that we can think about helping individuals who are suffering from memory impairment is, it's good to figure out what is disrupted, but then we also want to figure out what types of memory are preserved and how we can use it to bolster those more impaired systems. So the idea is to leverage more intact memory systems to support the ones that are suffering the most impairment. And one example of this that was a focus, again, of some of my prior research is the picture superiority effect. So we tend to remember images better than words. And this holds true even for individuals with moderate Alzheimer's disease. So they remember the picture of the apple better than they would remember the word apple. Images provide richer cues, which makes them easier to encode and subsequently retrieve. So that's why we might encourage using strategies like labeled pictures, visual reminders, and photo-based routines, based on the idea that this memory system might be more intact. Next slide. And another area that I have been interested in and done some work in is the use of music as a memory enhancer. So in Alzheimer's disease, the ability to process and respond to music is often relatively well preserved. Music engages multiple brain systems, so not only memory, but emotion, rhythm. So like pictures, it can act as a very strong cue. And some of my research has shown that pairing new information, so information that you want to remember, with music can increase memory performance in healthy older adults as well as individuals with mild Alzheimer's disease. So this work has potential for use in interventions in memory impaired populations. So, to kind of wrap up my part, so even though some memory systems do decline with both healthy aging and diseased aging, others remain strong or stable. And so we can use tools like pictures and music to support memory and improve quality of life. Next slide. So thank you. And I run the Memory and Cognition Lab, and am happy to talk more about my work in the question and answer series. So I'm going to turn it over to Dr. Mohan now.
Thank you, Dr. Deason. Hi, everybody. Thank you so much for attending this presentation, this talk. I am a speech language pathologist by training, and my clinical and research interests have primarily focused on how language changes in typical as well as atypical aging and age-related disease. Next slide. Communication is one of the most important foundations of daily life, especially as we age, and we often take it for granted until it changes. So for many older adults, language helps them stay independent because they can express themselves, their needs, And it also gives them a sense of agency when they're able to make decisions and contribute to conversations in the family. It holds relationships together because a conversation with a spouse, a joke with a grandchild, or a phone call with a friend are small moments that really help them connect to who they are, as well as to connect with others that they love. And in healthcare, it helps them. It's the difference between clarity and confusion. It can help them describe their pain, make decisions and follow their care plan, understand a diagnosis, etc. And so when communication changes as a person ages, it feels like the world can feel a little harder to reach. And so supporting communication and language as we age is not just about preserving skills, but it's also about maintaining independence, protecting dignity, and maintaining autonomy in life. Next slide. So it's important for us to differentiate language changes that are typical from those that may be related to clinical cognitive impairment. I'm not going to go over all these various language domains, but Dr. Deason mentioned, word finding as one of the early symptoms of typical aging. While vocabulary or word knowledge is typically maintained, tip of the tongue phenomena where you feel like you know exactly what you want to say but are not able to get the sounds of that word out, that can be common. It can be frustrating, and in typical aging is often related to words that are abstract or more unfamiliar or used less often. However, in Alzheimer's disease, even in the early stages, these word finding difficulties can even be for everyday objects or everyday words, and that can be quite concerning for family members as well as the individual themselves. Discourse is how we organize language or organize our ideas, and it's something that we can measure in narratives or in conversations. And while both groups may show reduced ability to provide informative information and reduce coherence, in Alzheimer's disease, it can be associated with difficulty providing clear and connected ideas. And in the early phase, they may display more of word substitutions or aborted phrases. But as the disease progresses, it can result in them having jargon in the middle to later stages. And eventually, a lot of individuals become mute, or they start disconnecting and even losing interest in communicating at all. Pragmatics is how we use language socially. And older adults, typically aging older adults, may have difficulty may interrupt more or may have some difficulty reading cues, such as when the other person's feeling bored or in knowing how much information they should share. With Alzheimer's disease, though, they may have more of difficulty staying on a topic and may even provide redundant information or repeat information over and over again. However, it's important to note that while language changes, the rate of decline of communication abilities is much slower than other cognitive functions. And so many individuals, even in the middle stages of Alzheimer's disease, are still able to maintain simple conversations and follow instructions. And so it's really important that we support this maintenance of language, and we design interventions that preserve independence and relationships so that individuals can still communicate as long as possible. Next slide. So I'll talk about a few evidence-based strategies that help in maintaining communication in individuals, especially those that have dementia. One of the key areas is the one that we have a lot of great evidence for is communication partner training. And what makes this approach really powerful is that this isn't about fixing the problem, fixing the communication decline of the individual with dementia, but instead it looks at how we can improve interaction between individuals and their caregivers. So we teach communication partners things like modifying the communication environment by improving lighting, reducing background noise, or minimizing visual distraction to reduce cognitive load so that the individual can stay engaged through the conversation. There are other things we teach them, like conversation techniques, like using simple and short sentences, using other cues like visual cues, written words, or gestures to enhance the information that they're providing. It can also mean we also teach them to sort of pace their conversation so that they can match the processing abilities of the individual with dementia. And then there's other things we teach caregivers to become more aware of their communication patterns. So often, unintentionally, caregivers may create stress, for example, by correcting the other person too quickly or asking too many questions. So behavior change training can help them in becoming more aware of these patterns and strengthen self-efficacy so that they can feel like they actually are at pace with the other individual and can provide information to the client, to the person with dementia more effectively. So all of these techniques help in reducing both cognitive and emotional load so that the person can stay engaged in conversations. Next slide. I've spent a few years as a speech-language pathologist, and I believe that speech-language therapy can be really helpful, not necessarily in just restoring lost language, but in preserving functional communication and maintaining language networks. So one of the most common declines we see is word finding that Dr. Deason and I both mentioned. And some treatment approaches can be very effective in relearning words as well as in maintaining communication and the retrieval of words. So errorless learning approaches guide the individual to produce words and to name things with minimal opportunity for error. Some recent really ecologically valid work is lexical therapy using narratives. So the evidence suggests that words are better supported when they are anchored in meaning and in connection, in lived experience. So instead of teaching them to retrieve isolated words, words are learned through stories, through conversations about familiar topics, functional narratives, and that can enhance those semantic networks, those that help us retrieve the meaning of words, and that can help in having more functional conversations. Next slide. There are some general cognitive stimulation approaches as well that specifically focus on language. So for example, using activities like reminiscence, group discussions about topics like food or childhood memories or current events help with providing opportunity for repeated language use. And storytelling can also be very helpful, telling personal stories, narrating existing stories. I've spent the last few years specifically focusing on storytelling and how that can be used as an intervention to enhance communication. Next slide. So the storytelling that I'll be talking about is part of a broader approach known as creative expression therapy. So you would have heard of creative arts therapies like visual arts therapy, music or dance therapy or movement therapy. And those can be really powerful in enhancing general cognitive abilities as well as well-being. But I'm talking specifically about those that have a language focus, arts, creative therapies that have a language or a communication focus. So there is a program known as Time Slips, which was primarily developed for individuals with dementia and focuses on using imagination and peer interaction to develop stories. So the way the program works is individuals are presented with a visual, a staged picture, like this one that you see of the man looking at the sea. And as a group, individuals with dementia have to interact and create a story from this picture. Time slips can be provided in a group setting, but can also be done one-on-one with caregivers and the individual with dementia. But the key aspect of this approach is that since it is focuses on the use of imagination and not on retrieving existing memories, it allows them to bypass any memory difficulties that they have and instead focuses more on engagement and social connection, as well as the creative use of language. This program has been, or versions of this program have been studied quite a lot, and there is strong evidence that it consistently supports improved communication and social connectedness. High quality studies have shown that it increases interaction of individuals with resident staff, greater frequency of interaction with their peers. And it also improves mood, and the stories that these individuals create have humor and playfulness, and that's really beneficial for providing that sense of identity for the individual themselves. When I worked worked in a study where we used this with individuals with dementia, I found it so fascinating, and the focus on language helped me adapt this program as an intervention for individuals with aphasia. So aphasia is a communication difficulty that occurs after individuals have a stroke or a brain injury. And so adapting this program was really effective because we found that it improved quality of life for these individuals. It also increased their communication confidence because they actually had the opportunity to practice language, which is an ability that was lost because of their stroke or their brain injury. And these individuals were also initiating communication more frequently, which overall increased their language abilities as well as their communication confidence. Next slide. So the key takeaway from this is that we likely cannot change the trajectory of the disease, but through these evidence-based strategies, we can meaningfully change how individuals experience communication every day. And I'm really passionate about using communication and language and supporting it using various interventions. Some of the interventions I talked about do have impacts on overall cognition as well, but the ones that I discussed are primarily those that can be used to support language. All right, next slide. Thank you.
Find my unmute button here. Yes, I would like to take a moment to thank Dr. Deason and Mohan for everything that they've shared with us about the everything they've shared with us so far today about diseases that led to cognitive decline, strategies for preventing and strategies for preserving memory function, and interventions that can mitigate these cognitive effects over time. Next, I am thrilled to turn the conversation over to Anna Tutum, who we will hear about. She is the director of Age of Central Texas's Memory Care Connections program. The Memory Connections program provides support to adult individuals and health partners who are navigating memory loss and cognitive impairment. Anna is a certified health education specialist with a master's of education in health behavior and health education from the University of Texas at Austin. Through her incredible work, Anna promotes evidence-based programming to support the quality of life, social connection, and brain health of older adults. Anna, thank you so much for spending your time with us this afternoon. I'll go ahead and turn the conversation over to you to continue.
Thank you so much. And thank you so much for this opportunity to present to this incredible group. I'm so grateful that a group like ECHO has come to exist in our community. We really think of Memory Connections as a translational program, bringing the work of incredible researchers like Dr. Deason and Dr. Mohan to the community. So thank you for the opportunity to share more about Memory Connections, a program that we love here at Age of Central Texas. So as I mentioned, Memory Connections, it's very important to me to also mention that it's just one program of many that Age of Central Texas supports older adults and caregivers to thrive here in Central Texas and have for the last 40 years. From our Thrive Center, Adult Day to technology. But Memory Connections, the program that I direct, is unique in that we specifically focus on folks who are living with early memory loss. We don't require a diagnosis, though a majority of folks in our program do have a diagnosis either of mild cognitive impairment or a dementia, most commonly Alzheimer's. But in the early stage, they're really looking for, we have found, peer support. So I like to use the word first and foremost community to describe Memory Connections. We provide a space and we provide relevant and stimulating content for our participants, but they support each other just as much as we provide any support for them. So what this looks like is actually largely an online program. COVID brought a lot of changes to many of our lives. This program used to be once weekly for any individual who was part of the program. During COVID, we shifted online out of necessity. As COVID ended and we had the opportunity to come back together in person, we looked at the research, we looked at best practices, and we talked to folks in our program and found that they preferred a hybrid model that allowed them to meet with frequency online. So we actually have opportunities every day for them to gather. And then with in-person options, a few times a month, so that they do still get to see each other in person and have that experience that nothing can quite replace of meeting each other in real life, which then just enriches their continued interaction online. So we are a hybrid program with a lot of touch points, which I think is really important for both the relationship building and habit building, as we'll see. So the reason that this program exists and has long existed to support specifically folks living with early memory loss and having a unique space for them is the care partners and participants of our program come to me saying things like, there's so many support groups for my care partner, but I'm the person with a diagnosis and I can't find anything for me. We have an incredible network of respite and adult day here in Austin, but I hear folks tell me pretty often, I just don't feel like I'm there yet. I really want to talk to people about living with memory loss and see how people are continuing to thrive. So the activities of Memory Connections are designed to be really purposeful. They're not just passing time, but they're adding quality to the lives of our participants. They are intentionally helping folks engage their minds. Dr. Mohan was talking about the importance of that cognitive stimulation, that general cognitive stimulation, that conversation, reminiscence, stories, and that generally enriched environment. So we want to be really intentional with engaging content. We also find that what keeps people coming back more than anything else is relationship. So we're really intentional about creating an environment that fosters authentic communication and real emotional support. And then we also bring a fair amount of brain health education as well to our participants and their care partners so that they can learn about modifiable risk factors and building healthy habits for brain health outside of their time in the group. So those are really the goals of the program. Based on the research and based on our identified interests in our participants. A few of the things that I think kind of are part of the secret sauce of why Memory Connections works is that hybrid element that makes it easy for folks to access Memory Connections, however that looks for them, whether it's that they're having transportation barriers and so they need to be online, or whether they really want to be in person. And so we have some in-person options. That is, I think, part of our secret to success, as well as being strengths-based and empowering, especially for this early stage. We really try to elevate the participant's voice and have it be a truly participatory program. So we have opportunities like town halls, lots and lots and lots of check-ins, as well as even creating activities together and co-leading activities with participants to elevate their voice and their ownership of the program, as well as using Memory Connections not as a space to isolate our participants, but actually as a springboard to support their continued and further involvement in the community by bringing in community members to talk or by bringing our folks out into all kinds of experiences in the community. So those are just a few kind of elements I wanted to highlight that I feel are some of the secret sauce that make memory connections something unique for early stage and really keep folks coming back. Because folks with in this early stage of the disease process are not going to keep coming back if they don't feel it adding benefit to their own lives. So all of that said, here's just a glance at like a typical week in memory connections. As you can see, we have a lot of touch points with, especially with my health promotion background and knowing the importance of habit for behavior change. We like having multiple touch points possible within the week. And we encourage folks to shoot for at least around 3 to really build relationship and habit and routine. We hear a lot that folks appreciate having routine to give some structure and anchors to their day. But folks can drop in. We do that not only so that they have a lot of options, but so that they know that they're empowered to choose what they want to come to. So once someone's part of the program, they get our full calendar. They have the same Zoom link for everything, trying to make it as easy as possible, just one click, and then we're hands off. Then we're just chatting, and folks can drop in based on their availability, based on their interests, based on their personal motivating factors for being in the program, whether that's more of their emotional support, and they want to make sure to always come to that peer support group so they can talk about the challenges and what they're learning as they live with memory loss, or whether they're not really about that. They don't want to focus on the disease process too much. They just want to keep building relationship and staying socially connected. Everyone's motivations are different. And so while we encourage folks to have a variety of sessions and to drop in regularly, the folks are empowered to choose when and how often they join us. I also want to call out our incredible community partners. We would not be able to offer so many in-person opportunities without this being a community effort. So we have a weekly in-person in collaboration with Westlake Hills. We're at the Cedar Park Library, Shalom Austin, and really looking forward to continuing to grow these community connections, knowing that within our communities of trust is where we're going to really reach people most. So just with so much gratitude to our current and hopefully continuing to grow community partners. And I just want to say a word about the impact of our programs. Anecdotally, we hear from our participants every day how much it means to them. And we're really honored that it's an important part of their daily lives. But some of the impacts, some of the outcomes that we have collected data on are belonging and social connection, which we have our highest agreement there of 94% feel that they find a place of belonging in memory connections. We also track quality of life overall, with 88% feeling an overall improvement in quality of life. And then even on some more difficult to budge measures like managing everyday life, it's not on here, but understanding brain health and modifiable risk factors, moving the needle on all of those outcomes. But their own words may say it best. So I highlighted a few of my favorite quotes up here where they've said things like, "It gives my mom something to get up for." So we know how important purpose is. And feeling like we're taking a proactive approach to diagnosis. So again, that self-efficacy and confidence that there is something that we can do. And as I speak to a group from the university community, I also want to make sure to shout out our incredible volunteers. We could not do this program as well without our wonderful volunteers, many of whom come from UT and from Texas State. So any professors out there that are helping their students find internships, we're always delighted to welcome volunteers and interns into the program. It also has an intergenerational element, I will say, that our participants absolutely love as they learn from each other. So That is the program in a nutshell. There's so much more to it, but I want to make sure there's plenty of time for Q&A. I believe we'll have a slide at the end with the information about contacting me and getting involved in the program. So thank you so much for